Okay, I think we'll pause now and get back to our sessions. Next speaker is Dr. Joseph Dillon, a friend and colleague for 20 years and a partner in our neuroendocrine tumor clinics, which number now 8 dedicated clinics per week, almost totally headed up by Dr. Dillon. And he's going to do his first talk on the important subject we already heard about, namely the value and the need for knowing about serotonin. Dr. Dillon?
Well, thank you, Dr. Odorizio, for the introduction, and it's great to be back at an NCAN symposium. Thanks for inviting me. So, yes, I'm going to be talking about the importance of controlling serotonin. And you've heard a great talk from Leanne Burns about that talks about issues related to carcinoid syndrome and serotonin, and we'll be reiterating some of those points, I think. So what serotonin is related to in our context is really it's related to the carcinoid syndrome, and you've heard a number of speakers today, from Dr. Liu's introduction through the other speakers explaining what aspects of carcinoid syndrome are. So aspects of carcinoid syndrome include flushing, diarrhea in 80 to 90% of people, wheezing, heart failure, also other aspects of episodes of high blood pressure, low blood pressure. There are a number of episodic symptoms that come into this rubric of carcinoid syndrome. And it's caused by hormones which come from the tumors. So carcinoid syndrome, carcinoid syndrome is present in a minority of patients with neuroendocrine tumors. About 10% of patients initially will have carcinoid syndrome. A recent big study from the folks at MD Anderson showed that 19% of people in a large database had carcinoid syndrome. Carcinoid syndrome symptoms do tend to increase over time. They usually start with tumors of the small intestine, though they can be seen with tumors in the lung and tumors in the ovary, for example. They do occur with other tumors, but mostly in the small intestine. And as other speakers have mentioned, mostly we see them when we see the onset of liver tumors. So, so what? Some flushing, some diarrhea. Is that a big deal? Well, yeah, it's a big deal, and I'm preaching to the converted here because many of you know that it's a big deal. There are nice papers in the academic literature confirming your experience. Another paper from the folks at MD Anderson looked at over 600 patients to ask, what really affects their lives most? What affected their function, their issues of anxiety, depression, and what they found was that carcinoid syndrome, and specifically the diarrhea and the flushing, that's what really causes decrease in their quality of life. So this graph here shows you that looking at bowel movements on the horizontal axis, patients who have more bowel movements basically have more anxiety and depression. Patients who have more bowel movements report decreased physical functioning. And basically the same sort of data for flushing. People who have more flushing have decreased physical function. They have increased depression and anxiety. So yeah, it's a big deal. It's also, and again, more data from the folks at MD Anderson who've shown some of the first studies that suggest that actually people with carcinoid syndrome do appear to have an increased mortality rate over people without carcinoid syndrome. So they took a group of almost 10,000 people in a large database, and what this shows is the overall survival over the years. And in the blue line, which is on top, is the people with no carcinoid syndrome, and you can see that they do slightly better than the people who have carcinoid syndrome. A lot of question about what this actually means, but there's the numbers. So what causes carcinoid syndrome? Carcinoid syndrome is caused by hormones and chemicals that are made from carcinoid tumors, and then mainly found, as I mentioned, are mainly expressed in those liver tumors. Carcinoid tumors make a multiple of different chemicals. Some of those chemicals don't do anything to, say, chromogranin A. Chromogranin A doesn't actually make you feel any worse. However, there are chemicals that are the basis of the symptoms of carcinoid syndrome. And some of those are listed here. So serotonin, many of the kinins, histamine, another important chemical from certain carcinoid syndrome, certain carcinoid tumors, prostaglandins, all of these can be a component of causing carcinoid syndrome. So serotonin is actually the best characterized of all of the chemicals that cause carcinoid syndrome, and so when we look at the effects of excessive serotonin in humans, some of them are listed here: diarrhea, which we'll talk about more. Carcinoid heart disease, so fibrosis in various places, fibrosis of the valves of the heart, causing damage to heart valves, causing heart failure. Another issue is mesenteric fibrosis, so fibrosis within the bowel, and it's something that Dr. Liu alluded to this morning and showed some pictures. And indeed, this fibrosis can cause abdominal pain, kidney damage, and fluid retention in the abdomen, for example. Niacin deficiency. So Leanne just talked about or came up in the questions, the issue of niacin deficiency and its associated rash, and also interesting studies on sort of the neuropsychology of having carcinoid syndrome, and the fuzzy brain and the anxiety, and these may be real biochemical issues that are seen in carcinoid syndrome and not seen in other non-neuroendocrine tumors. I've listed down below here some of the other aspects of the effects of serotonin, but I've put them in parentheses: carcinoid crisis, flushing. Both of these serotonin may have a role in, but doesn't perhaps have the predominant role. And one thing that was alluded to this morning was that there are some research data questioning whether serotonin actually has a role in increasing tumor growth, but that is really very much in the test tube level and unknown at this stage. So just to show you what mesenteric fibrosis looks like, on the right of your screen, on the left of your screen, we have a CT scan of a normal abdomen. You have the liver there on top, bowels down below throughout the abdomen. On the right panel, you have an area of mesenteric fibrosis, and there's a little white arrow there showing these spokes that come out from that central mass in the mesentery. This was very like a picture that Dr. Liu showed, the post-operative version of this morning. Another picture. This is a severe niacin deficiency rash, but basically these rashes are scaly. They're on the sun-exposed areas, and treatment with niacin improves the rash, as you see in the lower right-hand panel. So, how do we decrease our serotonin? And Leanne has given you great starting advice on that, and basically follow the dietary advice to decrease tryptophan, to decrease some of those amino acids that then become serotonin. There was a question about the 5 E's, and it essentially is trying to identify the situations that cause your symptoms, and whether it's all 5 E's or just the alcohol or just the exercise or just the eating, whichever situation, trying to avoid that situation, or use an injection of octreotide 30 minutes before engaging in that activity, and that would also take care of that increase in serotonin, which gives rise to some of those symptoms. There are medications which I'm going to talk about to decrease all of the hormones that come from neuroendocrine tumors. There are medications, or a specific medication to block serotonin itself, which I'm going to talk about as well. And then, as both Dr. Liu and Dr. Mayer alluded to this morning, one way to decrease serotonin is to decrease the amount of tumor in your body, particularly in the liver. So surgery, and to quote Dr. Liu, surgery, but also PRRT, liver embolization treatment, chemotherapy, all ways to attack the burden of tumor in the liver and the burden of tumor that's producing serotonin. So, what drugs can help decrease serotonin and help the carcinoid syndrome? So the oldest of the drugs in this group are the somatostatin analogs, and these are Octreotide, Sandostatin LAR, Lanreotide, or Somatostatin. They're going to improve both the flushing and the diarrhea because they decrease the production of all hormones, not just serotonin. This is a picture from the large Clarinet study, which showed that Lanreotide benefited folks with neuroendocrine tumors. And what you can see, so on the vertical axis, you have the marker of urine, HIAA. This is the breakdown product of serotonin in the urine. And on the horizontal axis, time. And you can see that once patients are administered Lanreotide, that urine 5-HIAA plummets. In the placebo, nothing much happens. Actually, it gets higher over time. And you can show the same data for Octreotide or Sandostatin LAR. They will both do the same things. This graph shows that both the short-acting Octreotide given 3 times a day or the Sandostatin LAR once a day, both will decrease the number of bowel movements. So, and we could also show the same thing with regard to flushing. So all of these agents will decrease all hormones and decrease manifestations of the carcinoid syndrome. One important thing that's become more widely understood recently is that there's been a tendency to put people on the usual dose of Sandostatin LAR and just leave them there, 20 or 30 milligrams. Well, actually, in patients who have recurrence of their flushing on the usual dose of Sandostatin or the usual dose of Lanreotide, or perhaps the flushing starts in the 3rd week of their 4-week cycle, just going up on their dose of Lanreotide or Sandostatin will further improve the flushing. So this was a study which showed that basically 80% of people, if they went above the usual doses of Sandostatin or Lanreotide, or if they made it 3 weekly rather than 4 weekly, they had an improvement in their carcinoid syndrome. So the usual way that I start people off is I start people off on Lanreotide at 60 or 120, Sandostatin at 20 or 30 4 weekly, and I increase the dose if the symptoms are not controlled. I can increase the dose by either shortening the time to 3 weeks if I can get the insurance company to cover that, or I can increase the dose by increasing the Sandostatin 40 milligrams or 60 milligrams, or indeed going up on the dose of Lanreotide, which I've done sometimes. Or I can just supplement either of these with short-acting Octreotide, which does the same thing as increasing the dose overall. So there is a new kid on the block, or a relatively new kid on the block, which decreases diarrhea, not so much flushing, but decreases diarrhea by decreasing serotonin production. And this is Telotristat or Xermelo, and it's used in addition to Sandostatin. So how does this work? Leanne sort of alluded to this already. how tryptophan in the body can go to produce niacin or produce protein. It's also the precursor of serotonin. And what happens in carcinoid syndrome is that more and more of it is sucked into serotonin, so less and less of it goes to niacin or other proteins. And what Xermelo or Telotristat does is basically blocks that pathway down into serotonin. So it drops the serotonin, it drops the HIAA, it improves the niacin, etc. And the outcome of that, and I think you saw this slide from Dr. Liu this morning, the outcome of that is a decrease in diarrhea. It drops the serotonin by about half and decreases the diarrhea. A couple of things to remember with Xermelo or Telotristat. It's used in addition to Octreotide and Lanreotide, so it's not used on its own. It's better absorbed with food. Short-acting Octreotide actually decreases its absorption, so don't take your Octreotide before Xermelo. Discontinue it if you get constipated. It's there for diarrhea. If you don't have diarrhea, please don't take this. They're in people who have side effects. Just start slower, 1 tablet a day rather than 3 tablets a day. And remember, it can take 8 or 10 weeks before you see the full effect of Xermelo, but 70% of people will get a benefit from this agent. Now, there are differences between Xermelo and Sandostatin or Lanreotide. So this figure here shows you those differences. So both of them decrease the serotonin. Yep. Both of them decrease the diarrhea. Yep. Only the Octreotide and Sandostatin will decrease other net hormones. So if you're getting a lot of symptoms related to histamine, Xermelo ain't going to do it for you. Decreasing flushing, maybe sometimes, maybe a little with Xermelo, but it's not. That's not what it's listed for. That is an effect, however, of the Sandostatin and Lanreotide. Does it decrease carcinoid heart disease? I would think that that's likely because carcinoid heart disease is related to serotonin. However, that's not been shown for definite, but frequently in my patients, that's one of the things that I will consider in considering use of Xermelo. Does it decrease tumor growth? Well, Sandostatin and Lanreotide do definitely decrease tumor growth. And again, it's an area of active research in terms of whether Xermelo does anything there. However, Xermelo is a tablet, and as you know, the Octreotide and Sandostatin are not. Do remember that not all diarrhea is carcinoid syndrome. So only carcinoid syndrome-related diarrhea is going to benefit from Xermelo or Octreotide or any other therapy that's related to neuroendocrine tumors. You can have bile salt diarrhea because you've lost your gallbladder and have a part of your bowel removed. That responds to something different. You can have bacterial overgrowth in your bowel, responds to something different. You can have side effects of the Sandostatin, responds to something different, pancreas enzymes. You can have pellagra, the niacin deficiency, which worsens diarrhea. Again, responds to something different. So, controlling serotonin to control the carcinoid symptoms. In summary, then, there's a key role of serotonin in the carcinoid syndrome, and we've covered the role of these 3 medications in relation to carcinoid diarrhea. And with that, and with greetings from my colleagues at University of Iowa, I think I'll turn it back to the moderator.